kids are depressed yet, or you just slow stuff down?
Well, I can only drink so much. I think it's like syrupy.
I know, I'm the same. Like I like taking like Dr. Pepper drink like every hour or so.
I drink a complex.
I drink like a 2 liter over the course of the day. To the point where it's flat, but I can't do anything about it.
Are we at 100% on the
Really? Yep.
Are you just going to post your address in that or like give it to us?
Yeah, I mean, whatever works. I think I put it on there. What? It looks over your face is funny.
Don't laugh. Don't laugh.
And I was just like,
Yeah, and then like you like put your head down. I'm like, don't even. I didn't laugh at all.
I can't.
I was not very good. Instead of like down for
I actually really love that I had I got them for like 3 weeks. My friend, she started on it, and it was like every time she wears a sweater, I was like, don't piss me.
I know, it's not Target. I want like giant like rollers that are like on my foot. I need that. I know.
Yeah, it's like the arch of my bed, and then it's from, like, I love that. Their sweat, they still have like average sleep on their I love wearing
Okay, let's go ahead and start that.
enough to like know what she's saying. I almost felt like following along with the PowerPoint, like knowing that it was in the PowerPoint.
Yeah, but like guys,
I don't know.
We'll leave the doors open because I think it keeps it a little bit cooler in here. Okay, this next section, I'm starting back on page 10. We're looking at big concepts. Do not worry about EC50, KD, Vmax, Emax. I'm not going to ask you those things. I want you to know the concepts behind what they're saying. So very first, drugs are designed to interact with a binding site either to elicit or augment the action of an endogenous substance, would be what an agonist does. Or to block or antagonize the ability of an endogenous substance to do its job. That would be an antagonist. Okay. So drug effect, first concept, drug effect is usually directly proportional to the dose for most drugs, not all, but most. So this is what that first graph is showing. So on the y-axis you have drug effect, okay, let's say it's blood pressure, and drug concentration. So the higher the drug dose or concentration in the blood gets, this is the response you get. So early on, you don't get much response. Let's say it's to here before you ever see blood pressure go down. As you increase the dose here, until you get to this 50% max, what do you see about the change in dose with the change in response? It's proportional, and it's about the same. If you go up, and let's say if the proportion is every 5 milligrams, make it up, you get the same expected response. It's proportional. I give 5 milligrams, I got a 2 milligram or 2 millimeter drop in blood pressure. Gave another 5, I got another 2 millimeter drop. That's proportional change. Usually, with most drugs, this is important, at lower doses, that will be the case. When you get to about that 50% max, you often, and this I'm just giving you in general, have hit about 80% of the effect of that drug. Okay? Because what starts happening here? Now I have to get more drug to get some effect. And eventually, I can't get any more effect for giving more drug. So here, the slope is flatlined. I'm giving more drug, no effect. Okay? So the things to take away from that, usually response is proportional to drug amount to a certain point. And once you hit that 50% max, now most drugs are not going to tell you this, but most of the time when you get to about the mid-dosing of a recommended dosing range, you're usually at about that point and you've gotten the most effect. To double the dose will not give you a double response at the higher ends. The other thing this does is it sets the drug recommended range. This is where they get it. This is the lowest dose that usually gives you a response. This is the highest dose that gives you a response. So now you know that it doesn't make any sense to keep increasing the dose to get more effect. I see providers do it. Don't exceed recommended dosage range. For the most part, it ain't going to help you. You can go to another drug, get more effect for your money, and less side effect. Okay? That's the takeaway. Questions? Yes.
If you continue past Emax, would it ever diminish the drug effect? Like, would that graph ever start coming back down?
No, I don't think so. I'm trying to think about it because I want to make sure I don't skip ahead too much because of this situation. So, I love colored chalk. It's the best thing they did when they put it down here. Okay, in the bloodstream, you've got albumin. Okay, most drugs, when they are absorbed into the bloodstream, most of them bind to some extent to plasma proteins. For the most part, albumin. That's the major place. So usually on this albumin, there's going to be sites. There's going to be places where this drug can join, bind. Okay, once you've saturated all that, you have drug out here. We call this free drug. Okay, that is the only drug that can exert a pharmacologic effect. Okay, can the bound drug to albumin do anything? No. Okay, so the free drug, so we got bound and free. The free drug can move out of the vasculature and can interact with the receptor. Okay, so drug enters the intracellular space and then it will sit on a receptor. Okay. If you do anything to alter that binding, let's say you give another drug that also likes those sites and says, get off my chair, like in musical chairs. Only got so many chairs, I got so much drug. So you could displace that, increase the amount of free. So that's one of the problems that happens. So this is the only drug that we're worried about causing effect. Okay. So receptors, the other thing that is in that little text there is that there's different affinities. So some drugs love their receptor and they get along fine, they fit together fine, and their affinity is high. And they may like to sit there a long time. Okay? So that's what that dissociation constants that it's talking about in there is. So if a drug has high affinity and low dissociation, you're going to get effect for a long time because it's going to love that receptor, it's going to sit there forever. If it has low affinity, it may get on there, get off, get on, get off. Don't like this one, go to the next one. Okay? So the affinity for the receptor also plays a role. The other thing that happens is the receptor numbers. So let's say I've got a ton of these ton. They can accommodate any free drug you put across there, it can take. That'll keep that flowing that way. That more unbound drug will move. And so as the free concentration goes down, some of that unbound drug will come off. So a receptor number plays a role in response. The affinity of the drug for the receptor plays a response. How long the drug will sit on the receptor plays a role in response. Will you know this? Will it matter so much? Not really. For the most part, you'll dose to effect, to clinical effect. In some patients, you will see a problem because their receptor response is going to be different from what we expect. So sometimes it can be due to receptor affinity, receptor numbers. Free drug, they don't have as much albumin. Low albumin for some drugs causes high toxicity because we can't bind enough of the drug that we're used to binding. So these are all factors. There are concepts to keep in mind. At this point in time, that's what I want you to know. We'll leave it back in as we go through different disease treatment. Okay? Yes.
I have a quick question. For the first graph, a Medrol dose pack, how like the patient takes, 8, 7, 6, 5, 4, is that like at the beginning, I guess they hit the 50% max point, but then after, is that how that works or no?
No, the reason we do that is we are trying to not suppress the adrenal system, the pituitary adrenal system axis to the point where it can't recover quickly when we take it away.
Okay.
So it's a different reason.
Okay.
Good, I'm glad you're thinking. Okay, so everything stays in equilibrium. That's another thing to keep in mind. The other big is only free drug can exert an effect. Okay. Next page. Let's talk about agonist and antagonists. So an agonist is a drug that will interact with the receptor and it will make the receptor do exactly what or for the most part, what the endogenous substance would do. Okay. So if I give insulin to a patient with diabetes, it will interact with that insulin receptor and do exactly what its native insulin would do. An antagonist sits on the receptor and blocks the response. So an agonist will always give you the pharmacologic response that you were expecting, and an antagonist will block it. So we give a beta blocker, we give a drug that will sit on a receptor that norepinephrine or epinephrine would interact with, and it blocks it from doing anything. These are important because we are going to talk about these all the time. Partial agonists are just what they say. They give you partial effect. So you get a lower response than you would have when it occupies the receptor versus the endogenous substance. And I've given you throughout your handout, there's little YouTubes that are short. You can go on. They give you a good visual, another way to look at the concept in a different way. Antagonists. Antagonists, like these that you're well familiar with, keep the agonist from doing its job. And we have different type of antagonists. We have competitive, we have non-competitive, we have chemical, and we have physiologic. So competitive, so if you look at this, it is in your handout. So a competitive antagonist will bind at the same site as the endogenous substance. And it will compete with that endogenous substance for that receptor site. So the effect of the drug is usually shorter, and you can overcome the effect by increasing the dose of the antagonist. So if you look at, so here's just the agonist alone. Here is your ED50, so this is your 50% of your drug and response. And the more antagonists you give, you keep moving out how much agonist you would need to get the same effect. So you can overcome an antagonist by giving more drug. If an antagonist is there, you can overcome it. So that's a competitive. Make sense? Okay, let's look at a non-competitive. Non-competitives are very strong. They will occupy a different site than the agonist. And usually the interaction is very strong interaction and it lasts longer. And it is hard for you to overcome it. So if you look at this diagram, picture, here is no antagonist at all. Okay? So the dose response curve is very, very high. Very small amounts of drug produce a big response. Your effect is on the y-axis, your dose of your agonist is on the x-axis. So a small amount of drug gives you more and more effect. If you use a competitive, which tends to be more irreversible over time, then you can't even attain the same effect. So giving more drug will not overcome a competitive antagonist. It takes time, longer periods of time for that receptor to just be regenerated. So the effect is long, it's strong, and you cannot overcome it. So know the difference between your competitive and your non-competitive antagonist. So these are very powerful drugs. And they last a long time. Chemical antagonists. So they deactivate the agonist. So antacids are a very good example. Physiologic antagonists do the opposite that the agonist did. So glucagon and insulin, hormones in the body, do opposite things. Insulin lowers blood sugar, glucagon raises blood sugar. If we can overcome the effects of insulin by giving a drug that opposes its action. Doesn't interfere with the receptor, doesn't interact at all with it. It has an opposite physiologic effect. Works by a different means to raise blood sugar. Works through the liver. Okay? So 4 different types of antagonists. Questions? Potency. Let's talk about that. So potency is defined as the concentration of the drug needed to produce an effect. So usually we don't talk about one drug being more potent than the other, usually in treatment, because we usually within the treatment of a disease will use equal potent doses. So if a drug can cause an effect with 1 milligram and it takes another drug 10 milligrams, it doesn't mean that the 1 milligram drug is more potent than the other, because they're equally potent. They produce the same response. But here are some. So if we were to classify drugs by low potency and high potency, you can see here is that here's your dose response curve. Here is your point where you get 50% of drug effect. So the dose is lower compared to this one on that end than the green, because the amount of drug that it took to cause the effect was much higher than the lower potency, the higher potency. For the most part, we don't worry about it in treatment because we will use whatever's equally potent in treatment to lower blood sugar, raise blood pressure, change calcium levels. Okay. That is potency. Efficacy. efficacy, again, is related to the dose-response relationship. This drug is very effective because very small changes in over a long period, over a long dosing range, the red, keeps getting effect. Whereas the one in green, over a very wide dosing range, you get very little change in effect. So low efficacy. Dose response curve. Really important to keep this one in mind. What this is showing you is, we don't do this very often, but with an opioid, because it has the potential for respiratory depression, we can look on the blue, shows you the analgesic effect. The red shows you the effect, the dose effect that produces respiratory depression. In between those two is the margin of safety. So we know that that is a dosing range or range of doses that we can use without evoking a poor response. This is important. This kind of rolls into this. So therapeutic window. Therapeutic window is the range between the minimum therapeutic dose and the minimum toxic dose. A lot of antibiotics, we use this with antibiotics. So this is plasma concentration of the drug on the y-axis. On the x-axis, it's time. Here is the curve. So this is the drug being taken, and this is the drug being absorbed. This is the peak effect. So this would be the maximum effect you would get out of that drug during a dosing interval. Then at that point, elimination tends to start taking over and we get drug out of the body. So as that occurs, then we're going to hit a point where we no longer get effect. There's too little drug in the body to cause an effect, and elimination has gotten rid of it. If we gave too much of the drug or it peaked too high, it would be in this red range. So therapeutic window is where we've got a response that we want and we've stayed under the toxicity. So an example would be an aminoglycoside. Antibiotic, very effective, but if the concentration gets too high, it will tend to move into the ear and it will destroy the ear in terms of hearing. The parts of the ear that are responsible for hearing. So we know that if we stay below a certain range and we stay above a certain range, we can get the kill rate that we want for the microorganism. We don't cause hearing loss and the patient recovers. That would be an example of a therapeutic window. A lot of the older drugs, we saw this a lot more as you see new drugs come out, they will try to get around this. They'll try to get around those toxicity and therapeutic range being close together. Here's another term we use for that, is therapeutic index. Drugs that have narrow therapeutic index mean that where they are therapeutic, where they exert the effect we want, and where they are toxic, either overlap or they're very close together. Those are drugs that usually we will monitor blood levels in order to keep the person out of toxicity and keep them in therapeutic range. So wide therapeutic index, those are great drugs, very safe. You can use them in a large number of people. Narrow therapeutic index. I'll ask you 100 times over the next year that term in class, because we'll hit these drugs periodically where there is a very narrow margin of safety. And that's therapeutic index.
Is that like vancomycin?
Vancomycin, a lot of the antibiotics fall into this. A lot of the anticonvulsants will fall into this category. Okay. Do you still have enough brain power left? Barely. When you study these, study the big concepts. That's all I want you to know. And they will work for us for a lot of class. What row do I usually run out of hand-ups on? Those of you, I'm always going to go up this side, sorry. So Shannon, I usually run out on you. Any on you? So I'm good on these lower groups? Okay. Now when you start moving around, then I get lost.
Some of them, yeah, down on your, like more effort together, so I'm just gonna use this and I'm just gonna go back and fill them out.
Go back and read it.
Yeah, that'll be a good way to study anyway, I think, for me personally.
Yeah, I will. That's why I'm highlighting and doing that right there, because I'll study. One more.
I don't know, yeah.
Do any of you all unpack? Do you all do hand-ups? Okay, let's see how many. You're probably short. Okay.
Yeah, we do. This is short. Yeah, and he.
Yeah.
I mean, at least that's on the schedule, right?
Okay. Thank you. Everybody get a handout? You did. Oh, sorry. Okay. All right. Okay, I'll tell you some more about me. No, we're not. Here we go.
What? Is that you guys young?
This is our son Cameron. He is a third-year medical student at OU, and then his wife, Ann Claire, our daughter-in-law. They've been married 2.5 years. I probably should update the picture, but we like her very much. There is Dr. Britton and I at the wedding. These are our animals. This is Schultz. As Dr. Britton told you about Schultz, I know you just want to gag at this point, don't you? And then this is Sammy. They're just sick together. And then this is our the cat. Her name is. She was my son's cat. Their dog couldn't deal with her, so I took her, and they named her Lieutenant Tiny Paws. So they called her LTP. So when we got her, I mean, she's little, and Schultz was scared to death of her. This cat can get him off his food bowl. I mean, he is 85 pounds. She is probably 6 pounds. If he is eating and she comes over and stands and looks at him, he will get off his bowl. It's hysterical. So we named her Lieutenant Tiny Terror. So I call her LT. Okay. And then this is Pepper. Pepper died last week. She's an Australian cattle dog, another dog that our son got and we inherited. She was almost 15. She had mast cell cancer, and she lasted about a year after they got her diagnosed. But she was a bullheaded dog, but she was a good dog. So that's our little group.
Dr. Britton didn't say you guys had a cat.
Of course he didn't. Because
We learned about Schultz.
he didn't tell you about Sammy? No. Or Pepper?
No, we learned a lot about Schultz.
About Schultz, yeah.
Schultz was even on one of our practice tests.
Really?
Guys, stop biting him out.
Yeah. Oh no, this is good. He doesn't like cats. He's tolerant. This cat is more like a dog, so he likes her. She's not afraid of him, and she will interact with him. Okay, so let's talk about kinetics. So pharmacokinetics, it's such good stuff. So absorption, how do we get drug in the body? Bioavailability, does everything we put in our mouth get to our bloodstream? How do we distribute drugs in the body? How do we metabolize them or biotransform? Sometimes we take inactive drugs and we make the body, we rely on it to convert it to an active drug. How do we get rid of drugs? What is the concept of steady state? What is a half-life? What are linear and nonlinear kinetics, and why do I need to know that? And then different dosage forms. So, this handout is much more in a explanatory instead of kind of a bulletin, but it's all there. So clinical pharmacokinetics is the study of the absorption, distribution, metabolism, and excretion of a drug. So you will often see it abbreviated the ADME. Pharmacists are simple, so it's ADME. The application of these is you can individualize drugs for a person or you can apply them to a general population. It's important to know them because alterations in these will give you an alteration in effect. You can't absorb the drug. If you have something that's interfering with absorption, you can't get the drug in. If you've got kidneys or liver are messed up, you can't metabolize, you can't get rid of a drug. If you have nonlinear kinetics, then very small changes will make very big differences in your drug effect. So pharmacokinetics deals with the dose concentration of drugs. So what's the dose of drug I gave and what was the concentration I got in blood, brain, liver, wherever you're sampling. Usually we're talking about blood. This is things we already went over, but pharmacologic effect is related to the drug concentration and access to a receptor. Okay? We talked about that. You've got to have the drug receptor complex in order to get an effect. Time course of drug access to the receptor influences time course of activity. So if there's lots of receptor and it has lots of access, then you get lots of effect. If you don't have access to the receptor, let's say some other drug you're giving is sitting on that receptor and won't let that drug affect. You won't let the drug sit on the receptor, then you'll get blunted effect. Greater drug concentration at the receptor, and the longer it's available, the stronger and the longer lasting effects. So sometimes we modify a drug or we modify an endogenous substance so that it looks like the endogenous substance, but it will sit there longer than it would if compared to what your body can make. So we can manipulate molecules in order to get that longer effect, longer sitting on the receptor. So that's what the chemists do. So the concept of minimal effective concentration and maximally safe concentration. Again, most drugs, this is so wide that it doesn't affect normally your use of the drug. Antibiotics, drugs that have a narrow therapeutic index will tend to, where this will be much more problematic. So again, that therapeutic range is between right below toxicity and right above minimal effective. If it's below minimal effective range, it's called subtherapeutic. It doesn't cause an effect. Or the effect is so minor we can't measure it. Toxicity then is when it starts to harm the patient, cause organ damage. Let's see. The concept of steady state. Let me do that once we talk about half-lives. Here's a wide therapeutic window. So most drugs fluctuate. You know that. They're going to rise, they're going to peak, and then they're going to fall off. Rise and peak and fall off, depending on how often you're administering this. So this one stays well below the minimal, or above the minimal effective concentration, and well below the minimal toxicity. Most drugs are going to fall in this range. And that's why you're gonna go, why do I need to know this? Well, it's the ones that don't that cause you trouble. So these are a narrow therapeutic index. The drug spends time below the minimal therapeutic concentration. When you do that with antibiotics, then the organisms can have a good time and multiply. When you have spent time above the toxic range, then the patient experiences toxicity. In the middle, you're getting the effect you want, but you subject the patient to risk below and above. So drug distribution, disposition, again, absorption, enters the bloodstream, stays in equilibrium with protein binding. Some drugs are highly protein bound. 99% of the drug you give binds to the albumin, so you just get this little free fraction. Other drugs, minimally bind. The drugs that are more highly bound, if you read or someone tells you this drug has a high protein binding, they are always at risk for drug interactions because a drug can knock them off, increases the free concentration of drug, you get more effect, more toxicity. So high protein binding comes into a problem when people don't have enough protein or they're taking drugs that compete for similar sites. So we have this drive towards, you see that both arrows are going into the bloodstream, but we have an equilibrium between protein binding and free drug. That free drug then is available to distribute wherever it goes. So the distribution, you see that is an equilibrium. It's going both ways, right? You can bind to the tissue, you can move back into the bloodstream. Some drugs will do that. But once it gets into the tissue area, it's going to stay in equilibrium either with the extracellular fluid, intracellular fluid, or the receptor area as well. Usually only drugs that are in the blood can then go through the liver and be metabolized. The liver's job is to change that drug into something that then the kidneys usually can eliminate. Sometimes the liver can just totally inactivate the drug. Okay, then we just get rid of it, the kidneys get rid of it anyway. Sometimes it converts it into a soluble substance that then the kidneys can handle more readily and get rid of. So they really work in tandem. Liver makes it possible so that the kidneys can get rid of the drug. That's why they both have got to work. If they don't work, can't get rid of a drug. And then you see here also drug that's eliminated comes out of the blood part, the blood compartment. If you think of these and kind of conceptualize at least drug movement in these kind of containers or compartments, it will make more sense. Yes?
When you're drinking alcohol and you take pills,
Yes?
is it because the alcohol is binding to those sites and causing more free drug to be in your bloodstream, and that's why like having increased
No, it's
effect?
usually interfering with metabolism. So it will, or it has the same effect as, if you take a CNS depressant and you take alcohol, you have doubling of effect. So some it's that, some of it's that alcohol is interfering with the metabolism of the drug. Mostly where we get into trouble is the same pharmacologic effect. Is that what is that? Okay, let's talk about absorption. So absorption is going to occur from you don't absorb out of the stomach, you absorb in the small intestines. Okay, so no absorption takes place out of the stomach. Got to get it to the small intestines. Once it's in the small intestines, then you got all those villi, there's lots of surface area, drug gets absorbed, moves through those epithelial cells, interstitial space, goes into the capillary. Capillaries have very small one-cell lining, so they're easily moved. Most drugs don't get hung up here. Most drugs can be freely absorbed if nothing else gets in their way. Okay. Dissolution takes place in the stomach, though. We use the effects of the acid in the stomach, the fluid in the stomach to dissolve. So most of the time when you take a dosage form, it's solid, right? So unless we usually don't chew up tablets or capsules, we swallow them whole. And we rely on that pH acid change to dissolve the tablet. Sometimes we can formulate a drug so that it can bypass that. So things that are enteric coated mean that we can get them past the stomach acid and we can put them into the intestines because we want it to slow down. Or we don't want it to irritate the stomach. So we can do a lot of things with drugs to keep them from dissolving in the stomach, or we may want them to dissolve very quickly and we'll enhance that. So we take advantage of that to either bypass it or to use it to our advantage. There are some dosage forms that where we get indirect absorption. So if we put drugs under our tongue, like nitroglycerin, then the absorption is very quick because it can enter into those capillaries and it doesn't go through the liver and it gets into the systemic circulation very quickly. So if we put things in buccal, is between your cheek and your gum, under your tongue, those can be absorbed very quickly. Okay? We bypass the liver, we got it right into the bloodstream. Other would be transdermal. You slap a patch on, it's absorbed right into the bloodstream. Sometimes we use that because, again, we get by the liver. Because if we swallow a drug and we go to the intestines, what drains the intestines? What big? The portal vein, right? Portal vein takes everything up to where? The liver. The liver, because the liver is the first big organ that can keep you from absorbing things that can harm you, right? Okay, so the drugs are part of that. So most of our drugs go through the liver before they ever get to systemic circulation. So once it gets through the liver, we consider that systemic. Then it can be taken all over the body. Okay? These forms are trying to get past that. So they don't want to have to go through the liver, either because the liver will destroy them all, or the liver slows everything down. So sublingual, very fast. That's why you put nitroglycerin on. A minute, we can get heart and chest pain to go away or go down. Transdermal, we slap it on the skin because we can get it around the liver, and that's usually to keep it from being metabolized. Pulmonary, sometimes we give things inhaler just because we put the drug right where we want it. So we inhale most drugs, we want them to go into the liver, into the lung. Intramuscular would be another way to get the drug quickly into the blood circulation and distributed without having to give an IV. Direct absorption. Direct is considered, if you put it into the bloodstream, that's one of the big compartments we want to get it into. It's the first compartment we move a drug into for distribution. Okay? So if you're direct, you are putting it right into it. That's considered direct. That's 100% available to the body. The body can take it and distribute it without going through any other system. It doesn't have to go through the skin, doesn't have to go through the little places in your mouth or through the stomach or through the intestines or the liver. Bypasses everything. So when we want to give drugs quickly, we give them IV. You can also give them intrathecal because we can put them right into the CNS fluid. The brain barrier has a very good barrier. It keeps a lot of things out of the CNS. So if we want to put directly into CNS fluid, we can give it intrathecally. We don't do very many drugs that way. Sometimes antibiotics, sometimes anesthetics. Factors affecting absorption. How the drug's made. Again, Technology is so good, we can make a drug absorb very quickly. We can make it release very quickly, and we can get a big burst. We can even design a tablet so that you have a core that dissolves right away and gives you effect, and then has an inner core that dissolves very slowly. So drugs for like attention deficit disorder, they will give you a drug that will dissolve very quickly, and for overnight, the kids wake up with more symptoms. So the immediate drug will decrease those, and then it has an inner core that dissolves very slowly and gives the child or the person taking it very slow amounts or low amounts of drug throughout the day. Biochemicals, so the size of the particles. So for some drugs, how big they are depends on can they move through a membrane. Will dictate that. Lipophilicity is a big thing. When you see lipid-soluble drugs, think drugs that will stay around forever. If it's lipid-soluble, and most people have enough fat on them, the drug will move into your fat, and it will stay there forever, a long time. Amiodarone is a drug like that. Amiodarone, once you stop taking it, it's a drug for an antiarrhythmic. It takes it 9 months to get entirely out of your bloodstream, or sorry, out of your body. Water-soluble drugs tend to have to be taken daily, or more often than daily, because the body can pee them out as quickly as you take them. It's like vitamin C and vitamin B. You take more than you need, the body just pees it out. It's very well you're solvent, we don't store it up. The lipid-soluble vitamins, A, D, E, and K, we can store that for long periods of time. We can build up reserves because they're fat-soluble. So the amount of solubility in a lipid base is very important for a drug in terms of how long it will be around. Acid-base properties, we take big advantage of acid-base properties. So some of the injectables, like insulin, very long-acting insulins, they will use the difference in pH of the drug in the tissue to get it to precipitate out and then be absorbed over long periods of time. So I'm giving you examples of how we use these things in order to change how a drug acts in the body. Bioavailability. This is an important concept. So when you take a drug, you take 100%. The amount that gets to the systemic circulation is always less than that, mostly. Okay? Some drugs may have a bioavailability of 3%. The statins have very low, 3 to 5%, which means of the 100 milligrams you took, 3 to 5 milligrams makes it to systemic circulation. Okay? So think of all the things it has to go through. It has to be absorbed, has to get into the gut, has to then get absorbed in the bloodstream, and then goes to the liver. So the liver plays a big role in removing things before we can ever get it to systemic circulation. Here's some examples of the effects of different dosage forms on bioavailability. So here's concentration of drug in the blood on the y-axis, x-axis is over time. You give something IV, there's nothing to prevent it. It's 100% bioavailable, and it gets into the blood circulation very quickly. IM, very similar, just takes a little bit longer to get absorbed. Tablets, effervescent tablets, so they very quickly dissolve and can be quickly absorbed. When you look at suppositories, rectal suppositories, very slow in their dissolving, very slowly absorbed. Tablets are this dotted line. You see, so bioavailability, so liver plays a big role. Keep that in mind. So when you're looking at drug literature, if you see that it has a very low bioavailability, sometimes that's why patients aren't getting an effect. Or if a drug interferes with a very low bioavailable drug, you may not be getting any absorbed. Sometimes you'll see do not take with food. That's because food either increases or decreases the bioavailability of the drug. And small changes could make big changes in their effects or in their side effects. So this is just a picture that shows you that take the dose, it gets absorbed, it's metabolized, could be in the gut wall metabolized, don't have very many drugs that happens to. Enters the portal vein, goes to the liver, liver gets rid of most of it, that's what is a bioavailable. What is available to the organism. So that's why transdermal is helpful in some cases, like with estrogen patches. Estrogen, if you give it orally, the liver gets rid of it. But if we put it in a patch, it bypasses the liver. So we get past that first pass effect. So that this phenomenon is called first pass effect. So if you read that a drug has a high first pass effect, it means most of the drug gets metabolized before it gets to systemic circulation. Rates of bioavailability. So the speed at which a drug is available to the systemic circulation, it will depend. Some can be very quickly, moderate would be within a few hours, and slow would be, I'm trying to think why I put this up here. Well, inhalers very fast, patches are slow. Usually your tablets and your capsules are going to be in that middle range, more moderate, within a few hours. Okay. Questions about absorption? Yes?
Do you know how drugs have differing effects on how they release? Because I know when I was working in a pediatric clinic, there was like one of the doctor would explain to the patients that there was like a initial peak, and then it drop down, and then a second peak for, so I guess that resistance didn't happen. Or not resistance, tolerance.
Yeah, was it for a child with attention deficit disorder?
Yes.
Yeah, that's a real common one. So what they do with those drugs, okay, they'll have a shell. That shell will get it past the stomach and into the intestines. And then it will have this top layer that will quickly go in solution as you get it into the small intestines. That will give you an initial peak, and that will occur within 30 minutes. Okay. Again, what I was saying is that children often, because they've gone without drug overnight, they'll wake up with symptoms of their condition. So this will usually get them under control very fast. Before they get to school, they'll be back under control. But what happens with this is that different ways that it's made, it will dissolve very slowly. So this will be gone within an hour. This will take 12 hours. Okay. Other drugs, cool one, this is a cool one. There are drugs that, this is where the drug itself is. It has a little hole in it at the top, and when you get it into the intestinal fluids, fluid comes in, will fill this space, and will act like a pump or a vice. And the fluid will just press this down, and the drug will exit. It's cool.
Is that like methamphetamine?
Hmm?
Is that like methamphetamine? Well, in the capsule stays, or is this capsule dissolved?
Some of them have a matrix that will not dissolve and will poop out, and others will dissolve. I can't think of the drugs off the top, but it's what we'll come across this one. It may be not that pink. Other questions? So distribution. So once you've got the drug in the body, getting it out to where it needs to go is the next step. So this is where you get into kind of compartments, because drugs like to go into different areas. And when they get into a different area, they will stay there longer in some areas than they will in others. We can take advantage of that and treat a disease in that area if we want, or we have to try to get the drug out of that area faster. So the drug usually enters the blood and then it can move into different tissues, different tissues where it'll react with receptor sites. It'll go through the liver and then also the kidney. So distribution, if you look at distribution values, it could tell you that the distribution of a drug is 3 liters. Which means if you were to drop the drug in 3 liters, that's the concentration you would get if you sampled the blood. Some drugs have distributions of 100 liters. What that tells you is that it goes all over the body. Small distributions usually stay within the vascular space and a little bit of it moves in and out of tissues. So large distribution, large dispersal into the body. That can be good and that can be bad. Usually it just is what it just is. It's the way the drug works or moves. Okay. Let's take a break. We'll come back at about 7 or 8 after, and I'll pull up the next. This one's in 2 parts. It's showing the picture.
Oh, it's on the YouTube. No, it's under I had to look for it.
Yes, yeah, I've had people do that with one of the old slow pay.
You want to see the breath cloud?
Yeah, and don't call, bring it over. Yeah, that's the truth. That's exactly right.
You do that?
So, is that, this is part 2?
Well, there's like there's one pharmacokinetics and there's one
Definitely sneezing more than
yeah, it's over multiple folders.
I just put it in the kidney.
Really?
Yeah.
Just follow along on my outline. Kinetics part 1, February 2018, first file. Kinetics part 2, 2018, second file. Unverified pharmacokinetics.
What about that?
Maybe it's Cisco 9.1.
Yeah, what do you use? Are you using the outline?
Well, Brittany said those are bad.
I try to follow along.
Yeah, but like they can still die.
I guess that's just
It depends on how much from there.
Yeah. I tried. Maybe I can ask you for those. Thanks, guys. You're great.
Is there pedals around?
And they told me, and
Take a while.
they were like,